The following presentation is on important landmark statin trials. Before we present the landmark trials, we will first discuss the lipid hypothesis, the Framingham and Mr. Fit epidemiological studies, and the NCEP ATP3 guidelines, as well as a few other key important statin trials. There will be two presenters for this podcast. My name is Todd Omrine, the first presenter, and I am the training manager for the WellCall brand team. With me today is Carolyn Silverman. Carolyn?
Hi, as Todd said, my name is Carolyn Silverman. I will be your second presenter today. I am a registered dietitian and certified diabetes educator. I am the national manager for the WellCall Clinical Educator Program. WellCall clinical educators are field-based and provide basic information on type 2 diabetes and primary hyperlipidemia, tips for maintaining a healthy and active lifestyle, and strategies to help adult patients stay on therapy.
Thanks, Carolyn. Let's get started. This presentation discusses the statin class of cholesterol medicines. A part of this discussion is that of epidemiological and landmark outcomes studies in which lowering LDL-C with statins has shown macrovascular risk reduction in the patients in those trials. The effect of WellCall on cardiovascular morbidity and mortality has not been determined. These studies did not include WellCall. It cannot be implied or inferred that WellCall has similar outcomes.
Now let's briefly discuss the lipid hypothesis before the landmark trials. A large number of studies have demonstrated a direct relationship between elevated levels of total cholesterol and LDL-C, and the risk of developing coronary heart disease or CHD. This relationship is continuous, starting at a total cholesterol level of about 180 milligrams per deciliter, but it becomes particularly strong at higher levels of cholesterol. Thus, a patient with a total cholesterol level greater than 240 milligrams per deciliter has a greater risk of developing heart disease than a patient whose total cholesterol is less than 200 milligrams per deciliter. Clinical studies have further shown that the risk of CHD can be decreased by lowering total cholesterol and LDL-C. Together, these two observations about cholesterol and CHD are known as the lipid hypothesis. Remember, WellCall was not included in any of these studies. WellCall is indicated to lower LDL-C, but has not been shown to impact CHD. The Framingham Heart Study, published in 1984, and the Multiple Risk Factor Intervention Trial, known as Mr. Fit, published in 1986, provided the largest body of evidence for the lipid hypothesis, showing that the incidence of CHD is positively associated with elevated total and LDL-C levels.
These two large epidemiological studies showed that for each 1% increase in total cholesterol levels, there is a corresponding 2% increase in the risk of CHD. And for each 1% increase in LDL-C, there is a corresponding 1% increase in the risk for CHD.
Because the number of people with very high total cholesterol levels was much smaller than the number with moderately elevated cholesterol levels, the proportion of the study population experiencing CHD events was greater at lower levels of total cholesterol. Framingham data thus support aggressive cholesterol lowering to reduce the risk of CHD in patients whose cholesterol is only moderately elevated, not just in patients with very high cholesterol levels. As you noticed on the previous slide, Framingham was published in 1984, while Mr. Fit was published in 1986. The National Cholesterol Education Program was established in that same time frame in 1985. Commonly referred to as NCEP, they published their first guidelines, ATP1, for cholesterol management in 1988. The impact of trials over the years has impacted NCEP, whose goals have become ever more aggressive with LDL-C. Some of the trials which have helped to bring about these changes by showing that aggressive LDL-C lowering is better than standard care are listed. Adult Treatment Panel 2 was published in 1993. Soon after, in 1998, the AFCAPS-TEXCAPS trial results were published. This trial influenced NCEP to publish Adult Treatment Panel 3 in 2001. This was followed by more trials showing that lowering LDL-C even further is better than standard care. The HPS, ASCOT, Prove It, and Reversal trials thus were considered by NCEP in their Adult Treatment Panel 3 update in 2004. This update will be discussed on an upcoming slide. But first, let's take a look at the following studies which NCEP considered in their ATP3 update. The Heart Protection Study was a secondary prevention trial published in The Lancet, July 2002. HPS provided significant new information at the time regarding the benefits of statins. It was an intent-to-treat 2x2 factorial design, which studied the use of simvastatin 40 milligrams and vitamin supplementation with vitamin E, vitamin C, and beta-carotene in 20,536 patients who were at risk of cardiovascular disease.
In addition to a mean LDL-C reduction of 39%, the major findings from this trial included the following benefits in the simvastatin 40 milligrams a day treated patients: a 24% reduction in any major vascular event, 18% reduction in coronary deaths, 27% reduction in major coronary events, 25% reduction in stroke, 24% reduction in revascularization procedures, and a 12.9% reduction in all-cause mortality. The authors noted in Table 1 of the study that the 5-year compliance rate for those taking simvastatin was only 82%, while 32% of patients in the placebo arm had begun statin therapy. The authors speculated, therefore, that the 24% risk reduction obtained in major vascular events in this intent-to-treat trial would have been approximately a third had patients been compliant.
The benefits of statin therapy were seen in a number of subgroups of patients who were poorly represented in previous trials. These subgroups include the elderly, greater than 75 years of age, women, individuals with no vascular events, those with known cerebrovascular or peripheral arterial disease, and those with LDL-C less than 100 milligrams per deciliter. These findings indicated that cholesterol lowering with the statin is of value in a much broader population, including those with low or normal lipid values. Finally, the authors of HPS noted that the benefits of the statin were additional to those of other cardioprotective treatments, and in their commentary, they mentioned that in a smoker with vascular disease, quitting smoking and use of 4 simple preventive strategies could theoretically have large potential benefit, say around 80% relative risk reduction. The 4 strategies mentioned by the authors were aspirin, beta blockers, lipid lowering, and ACE inhibitors. The ASCOT trial published in The Lancet in April 2003 was an independent, multi-center, randomized trial designed to compare 2 antihypertensive treatment methods for the prevention of CHD events in more than 18,000 patients with hypertension but no history of CHD. In addition, the trial included a lipid-lowering arm investigating the cardiovascular effects of atorvastatin versus placebo among patients with a total cholesterol concentration of 254 milligrams per deciliter or less. The original ASCOT trial randomized 19,342 hypertensive patients aged 40 to 79 years with 3 or more CV risk factors to one of 2 antihypertensive treatment groups. The lipid-lowering arm of the study randomized 10,305 of the original participants with LDL-C levels less than or equal to 254 milligrams per deciliter to concomitant treatment with atorvastatin 10 milligrams or placebo. The combined primary endpoint of the lipid-lowering arm was fatal CHD and non-fatal MI.
After 1 year of follow-up, LDL-C among patients taking atorvastatin was 35% lower than those taking placebo. Results of the trial demonstrated that in hypertensive individuals who on average were at moderate risk of developing cardiovascular events, lipid-lowering treatment with atorvastatin 10 milligrams reduced the risk of fatal CHD and non-fatal myocardial infarction by 36% compared to placebo. This curve of separation shows that the benefits of atorvastatin versus placebo were apparent within 30 days and remained for the duration of the trial. ASCOT was supposed to be a 5-year trial, but was stopped early at 3.5 years, showing that lipid-lowering treatment with atorvastatin 10 milligrams reduced the risk of fatal CHD and non-fatal myocardial infarction by 36% compared to placebo.
The PROVE-IT study was published in the New England Journal of Medicine in April 2004.
The intent of PROVE-IT was to compare the standard degree of LDL-C lowering to about 100 milligrams per deciliter, which would correlate to NCEP ATP3 guidelines, using pravastatin versus more aggressive LDL-C reduction to about 70 milligrams per deciliter using atorvastatin as a means of preventing death or major CV events in persons with acute coronary syndrome. The 4,162 patients consisted of those who had been hospitalized for an acute coronary syndrome, defined as acute myocardial infarction or high-risk unstable angina in the preceding 10 days. They received standard treatment and in addition were randomized to double-blind treatment of 40 milligrams of pravastatin or 80 milligrams of atorvastatin each day.
For those patients who were not on previous statin therapy at baseline, pravastatin reduced LDL-C by 22% to 95 milligrams per deciliter, which is just below the NCEP ATP3 goal of 100 milligrams per deciliter, while atorvastatin lowered LDL-C 51% to 62 milligrams per deciliter, which is just below the optional goal of 70 milligrams per deciliter. Associated with this additional LDL-C reduction of 51% versus 22%, there was a 16% reduction in the hazard ratio favoring atorvastatin in the primary endpoint of the trial. The authors reported, and this curve of separation shows that the benefit of high-dose atorvastatin as compared to standard-dose pravastatin was evident as early as 30 days into the trial and remained consistent over time.
The reversal study published in JAMA in March 2004 also compared high-dose atorvastatin 80 milligrams versus pravastatin 40 milligrams. It was a double-blind, randomized, active control, multi-center trial conducted in 34 care centers in the U.S. The objective was to compare the effects of intensive versus moderate lipid-lowering drug therapy on progression of coronary artery atheroma.
Atorvastatin lowered LDL-C 46.3% to 78.9 milligrams per deciliter, while pravastatin lowered LDL-C 25.2% to 110.4 milligrams per deciliter. HDL-C, trigs, ApoB, and C-reactive protein were also measured. The primary endpoint was percent increase in the volume of existing atheroma in designated blood vessels. Progression of coronary atherosclerosis occurred in the pravastatin group while it did not progress in the atorvastatin group. For any degree of LDL-C lowering attained during the study, the progression of atherosclerosis was slower if the patient attained that cholesterol level through treatment with atorvastatin.
The study outcomes challenged the understanding of CAD as a progressive condition that inevitably worsens. The reversal study suggested that intensive LDL-C lowering with atorvastatin 80 milligrams may potentially reverse the progression of atherosclerotic disease. Due to all of the results of the trials we just discussed, the NCEP ATP3 goals were updated in 2004. The update modifications are indicated in blue. The modifications can be summarized as follows. Recent statin studies suggest that further risk-reducing benefit could be achieved by lowering LDL-C to a level substantially below 100 milligrams per deciliter. Therefore, in the 2004 update to ATP3, while the LDL-C goal of less than 100 milligrams per deciliter can be kept as a strong recommendation, a goal of less than 70 milligrams per deciliter has been suggested as a therapeutic option for patients in the category of very high risk. The 2004 update recommends that if drug therapy is used for cholesterol management, it is advisable to use doses that will incur at least a 30% to 40% reduction in LDL-C. Alternatively, such reductions of 30% to 40% can be achieved by combining lower doses of statins with other agents, such as bile acid sequestrants, nicotinic acid, and ezetimibe. Also, according to ATP3, LDL-C lowering agents were not required for moderately high-risk patients with an LDL-C in the range of 100 to 129 milligrams per deciliter. Instead, LDL lowering agents were optional. However, the 2004 update recommends that drug therapy be considered for moderately high-risk patients with an LDL-C in the range of 100 to 129 milligrams per deciliter. While the new statin studies support the ATP3 recommendations concerning the benefits of lipid-lowering therapy in persons with diabetes and the elderly, they suggest a more aggressive approach for high-risk individuals with relatively low LDL-C levels. NCEP ATP3 recommends 9 steps to treat lipids. It's a complicated chart. Let's make it easy. The first step is to do a cholesterol test after a 9 to 12-hour fast. Second is to identify atherosclerotic disease. Steps 3 through 5 relate to identifying risk factors such as smoking, hypertension, low HDL cholesterol, family history of premature CHD, and age. Remember, type 2 diabetes is considered a CHD equivalent, while an HDL-C greater than or equal to 60 milligrams per deciliter negates one of the other risk factors that may be present in an individual. Step 6 is to initiate therapeutic lifestyle changes, or TLC, such as diet and exercise. If diet and exercise do not work, drug therapy is indicated in Step 7, and LDL-C thresholds for pharmacologic intervention vary by risk level, as do the LDL-C goals. Steps 8 and 9 involve identifying and treating the metabolic syndrome and triglycerides. This is the NCEP ATP3 treatment algorithm. As you can see at the bottom left corner, statins are the typical drug of first choice. However, an HCP can also start a patient on niacin or a bile acid sequestrant, such as Welchol. Please note Lovaza and Zetia were not yet approved at the time NCEP ATP3 was published, and are therefore not mentioned. The emphasis is on lowering LDL-C first. After 6 weeks, if a patient is not at their LDL-C goals and on a statin, the HCP should consider a higher dose statin or adding on another agent. After another 6 weeks of LDL-C lowering, the HCP should consider altering other lipid risk factors such as HDL-C and triglycerides. Finally, the HCP should monitor the patient every 4 to 6 months to make sure the medicines are working and that the patient is compliant. Now that we've covered the NCEP guidelines, let's discuss the landmark statin trials. The West of Scotland Coronary Prevention Study, or WASCOPS, published in the New England Journal of Medicine, November 1995, studied 6,595 middle-aged men with high total cholesterol, mean 272 milligrams per deciliter, and LDL-C, mean 192 milligrams per deciliter, but without a prior MI who received pravastatin, 40 milligrams per day.
Patients in WASCOPS experienced a 26% reduction in LDL-C. Pravastatin therapy was associated with a 31% reduction in the combined endpoint of non-fatal MI or death from CHD. The benefit was independent of age, cigarette smoking, multiple risk factors, or pre-existing vascular disease.
The Air Force Texas Coronary Atherosclerosis Prevention Study, published in JAMA, May 1998, enrolled 5,608 middle-aged and elderly men and 997 women without CHD and with borderline high total C, mean 221 milligrams per deciliter, and LDL-C levels, mean 150 milligrams per deciliter, and low average HDL-C levels, mean 36 milligrams per deciliter. Study participants received lovastatin 20 or 40 milligrams per day or placebo. The goal of therapy was to reduce LDL-C to less than or equal to 110 milligrams per deciliter, which was a more aggressive goal than is usually recommended for patients without CHD at the time. The study was terminated after an average follow-up of 5.2 years because of the increased efficacy of active treatment compared with placebo.
Lovastatin recipients lowered their LDL-C 25% and showed a 37% reduction in the risk of a first acute major coronary event. AFCAPS-TEXCAPS was the first primary prevention trial to show that lipid modification in generally healthy men and women reduced the risk of developing CHD.
The Scandinavian Simvastatin Survival Study, or 4S, was published in The Lancet in November 1994. Simvastatin reduced LDL-C levels 35% in 4,444 patients with angina or previous MI.
These reductions were associated with a 30% reduction in the primary endpoint, total mortality. 4S was the first lipid-lowering trial to show a reduction in total all-cause mortality. Simvastatin therapy also significantly reduced the risk of any coronary event and CHD death by 34%. Risk reductions were independent of age and gender.
The Cholesterol and Recurrent Events, or CARE trial, published in the New England Journal of Medicine, October 1996, studied 4,159 men and postmenopausal women with a prior MI who received pravastatin 40 milligrams per day.
CARE showed a 28% reduction in LDL-C compared with placebo. These reductions in cholesterol were associated with a 24% reduction in the combined endpoint of CHD death or non-fatal MI.
The long-term intervention with pravastatin in ischemic disease, or lipid study, was published in the New England Journal of Medicine, November 1998. It was a large landmark statin trial, enrolling 9,014 patients, and included patients with the widest range of baseline cholesterol levels. Total cholesterol ranged from 155 milligrams per deciliter to 271 milligrams per deciliter. Lipid was terminated early because of the efficacy of active treatment compared with placebo.
Patients treated with pravastatin 40 milligrams a day had a 25% reduction in LDL-C. This was associated with a 24% reduction in the primary endpoint, CHD death.
One final study I would like to present is the Jupiter study, published in the New England Journal of Medicine in November 2008. While Jupiter is not a landmark statin trial in the traditional sense, it does add to the statin outcome story. It was a randomized, double-blind, placebo-controlled, multi-center trial designed to determine whether treatment with rosuvastatin 20 milligrams daily would decrease the rate of first major CV events. The background for this study was evidence from multiple studies that showed increased levels of high-sensitivity C-reactive protein, or hsCRP, are predictive of CV events, that statin therapy reduced levels of hsCRP, and that the magnitude of benefits associated with statin therapy correlated in part with the reduced level of hsCRP. A total of 17,802 men aged 50 or older and women aged 60 or older with no history of CVD, LDL-C levels less than 130 milligrams per deciliter, and hsCRP levels greater than or equal to 2 milligrams per liter were randomized to receive either rosuvastatin 20 milligrams per day or placebo.
The Jupiter trial was terminated before its anticipated end date of 5 years after a median follow-up of 1.9 years. Rosuvastatin reduced LDL-C levels by 50% and hsCRP levels by 37%. Rosuvastatin was associated with a 44% reduction in the primary endpoint, which was the occurrence of a first major CV event defined as non-fatal MI, non-fatal stroke, hospitalization for unstable angina, and arterial revascularization procedure, or confirmed death from CV causes. Rosuvastatin was also associated with a significant decrease in each of the individual components of the primary endpoint, as noted in the secondary endpoints column. In terms of safety, there was no significant increase in the incidence of myopathy or newly diagnosed cancer in patients taking rosuvastatin. However, as noted by the FDA alert, of the 17,802 patients in the study, 270 of the 8,901 patients in the rosuvastatin group and 216 of the 8,901 patients in the placebo group had physician-reported diabetes, resulting in a 27% higher incidence of physician-reported diabetes in the rosuvastatin group. This demonstrates the curve of separation showing that rosuvastatin was associated with a 44% reduction in the primary endpoint. These are the statins currently available on the U.S. market, along with the 5 combination products available with a statin component.
After diet and exercise, statin therapy remains the gold standard for treatment of hyperlipidemia and is often chosen as first-line therapy due to efficacy and strength of data on clinical outcomes. Many patients cannot achieve NCEP ATP3 lipid goals on a statin alone, or cannot tolerate statin therapy due to elevated liver enzymes or myopathy, especially at higher doses. There are FDA concerns about higher doses of some statins like simvastatin. Niacin, ezetimibe, or bile acid sequestrants such as Welchol can be added to statin therapy to get patients closer to their lipid goals. The effect of Welchol on cardiovascular morbidity and mortality has not been determined. Remember, Welchol was not included in any of these studies. Welchol is indicated to lower LDL-C, but has not been shown to impact CHD.
You can find more information on the landmark trials and statins by visiting the WellCall resource website. On the website, you will find the WellCall Home Study Binders under the Learning Tools tab, all of the important package inserts for the full prescribing information, 2 or 3 page summary fact sheets, the online CAT, which is playable on both your laptop as well as your iPad, the 2012 Meet Your Marketplace Guide, which you can also order through Hibbert, and various training bulletins addressing this class of medicines. Thank you.